Welcome back, everyone. We're going to get back started for the afternoon sessions. So we have like I mentioned earlier this morning, we have a great privilege this year to have a lot of youth engagement in our day today. And in particular, it's nice when there's an intersection between lived experience and being involved in research. So it's my pleasure and honor to introduce Kristen, who's currently a PhD student in the Department of Physiology at the University of Toronto. She's been a member of our Youth Advisory Council since 2021 and will be chairing this afternoon's session focusing on clinical and psychiatric patient settings. So please join me in welcoming Kristen.
Thank you very much, Dr. Goldstein. It is my pleasure and honor to introduce our first speaker, Mauricio Tohen. Mauricio Tohen is a University Distinguished Professor and Chairman of the Department of Psychiatry and Behavioral Sciences at the University of New Mexico in Albuquerque, New Mexico. He was born in Mexico City. He attended the Faculty of Medicine at UNAM. He completed a residency in psychiatry at the University of Toronto and a fellowship in psychopharmacology at McLean Hospital/Harvard Medical School. He also obtained a doctorate in epidemiology at Harvard School of Public Health and an MBA from Indiana University. A lot of letters after his name. In 2014, Dr. Tohen was recognized in Thomson Reuters, the world's most influential scientific minds in 2014. He was one of the 100 scientists worldwide recognized in the psychiatry/psychology category. Dr. Tohen has published over 370 publications and has over 40,000 scientific citations. In 2016, the International Society of Bipolar Disorders awarded him the Mogens-Schou Award for Education and Teaching. In 2017, Dr. Tohen was recognized by Expertscapes as having the top 0.12% expertise in bipolar disorder worldwide, based on citations of published articles between 2007 and 2017, and between 2010 and 2020. In 2024, Dr. Tohen's total citations added up to 40,814 with a D index of 106. Please join me in welcoming Dr. Tohen.
Thank you, Kristen, for the nice introduction. And congratulations, not only in the meeting, but what I've learned of the Youth Bipolar Advisory Group. This is a way to do it, and I can confess we don't have that in New Mexico. So every time I give a presentation, I learn something, and this is great. So congratulations to all of you. So yes, I guess I was born in Toronto, as you can tell from my accent, not literally, but professionally. So this is a very special place for me. Actually, when I was here, most of you were not even born. This was Queen Street was a large place, and then I got here, I didn't recognize it. So it's always good to be back. So my presentation is going to be a little different, and we're talking about clinical settings, and I'm going to talk about New Mexico, and I'm going to talk about the experience in the psychiatric emergency room. Those living with bipolar disorder are not strangers to the psychiatric emergency room. So but I'm not going to focus on bipolar disorder. I'm going to focus on the emergency needs that we have in New Mexico there's going to be some similarities, but some difference with Ontario. To start, is you have a better system of health than we do. So, this is not changing.
It's for some reason mouse dependent.
I didn't mess it up.
There you go.
Oh, thank you. Okay, thank you. And actually, Ben just reminded me that we met 20 years ago, right? Anyway, so again, a pleasure to be here. So I've been in academia, and I also work for industry. My background, I'm not a pharmacologist, I'm an epidemiologist. So when I work in industry, I was involved in the design of clinical studies. So I still do consultation for anybody who wants to bring a new drug that is bipolar disorder. I think it is important for industry. They develop the drugs, and academia, we advise them on who needs them and the design of the study. So as you can see, I have been involved in consulting with them, but I'm not going to talk about any medications today. So the challenges that we have in New Mexico, and one of them is actually mental health, specifically suicide, but another one is substance use disorder. When it comes to adolescents, actually New Mexico is usually top 3 in things you don't want to be top 3. It is among the 3 poorest states in the U.S., together with West Virginia and Mississippi, and it is the state with the highest rate of suicide in adolescents, and it's also related to Native Americans. New Mexico is also unique. Actually, I always like to talk about New Mexico. Number one, it is not new, and it's not part of Mexico. Actually, when Spain had its colonies, Mexico was known as New Spain, Nueva España. And actually, the conquistadors, the last one actually was from Mexico, who went to what is now New Mexico, called it Nuevo Mexico. So in a way, the state of New Mexico existed before as the country of Mexico. That's an interesting piece of information. Another one, the capital of the state, Santa Fe, is the oldest capital of any state in the U.S. So if you ever have a chance, visit Santa Fe. It's really a beautiful place. Back to our lecture. Substance use disorder, big problem, and as mentioned, especially in adolescents, and it's very high in the Native American population. When it comes to substance use disorder in minors, it is the 3rd highest in the U.S. after Montana and South Dakota. I mentioned this is one of the things that we are top 3. Teenagers in New Mexico are close to 40% more likely to use drugs than in the rest of the U.S. 11% of 12 to 17-year-olds have used drugs in the last month. Now, the most frequent drug is marijuana. Marijuana actually was legalized in New Mexico, I think it was 3-4 years ago. Was it good or was it bad? It really depends. Like nothing in life, it's not a clear yes or no. It is bad for adolescents. A number of studies have shown that use of marijuana decreases the age of onset of psychosis and bipolar disorder. Individuals who suffer from bipolar disorder, if they use marijuana, the risk of relapse increases. So it's something that we need to be very careful with. There's 18%, close to 20% of the adolescents in New Mexico used it in the last year. The use of other drugs is much lower, as you can see, cocaine, methamphetamines, heroin, and actually also painkillers, much lower. But that doesn't mean that marijuana is benign. Now, what is the good use about legalizing marijuana? That is better for law enforcement to go after people who commit major crimes than as opposed to going after teenagers that are using marijuana. So that is the the good thing about legalization. That's just my opinion. Alcohol, it's actually less of an issue in New Mexico than in other states, although as you can see, 8% is not small, but less likely than in the rest of the U.S. Apologies that I don't have data comparing it to Canada, and I'm sure it's different than in the U.S. As you can see, a good amount of 18 to 25-year-olds used drugs in the last month, and it is actually more common, 2% higher than in the rest of the U.S., and 4% of adolescents use drugs in the last year, and as mentioned, less frequent, less than 2% for the use of alcohol. So here is the use of the rate of suicide. As you can see, in New Mexico is very high. And if you look at the states that are higher, you know your geography, so you know that all these are northern states. So the only one that is not a northern state is New Mexico. It's the fifth highest after the Alaska, South Dakota, and other states. Now, use of emergency services, which is a key point. The use of emergency departments has increased in terms of mental health in the last few years. And in the US, it's really a safety net. Instead of having a walk-in clinic that I saw you have one across the street, patients go to the emergency room. That's because of the lack of a safety net. But this is, of course, patients who should be at the emergency room is mostly for medical emergencies. I'm not minimizing psychiatric emergencies. What we have now is a psychiatric emergency room, but that is different as opposed to going to the main ED. The problem, and this happened a lot during COVID, is that patients with psychiatric conditions, I'm going to focus on psychiatric conditions, would stay more than 24 hours, 72 hours in an emergency room because there was no place to transfer them in any other place. So the length of stay has increased, and really the emergency rooms are not well equipped to treat mental health needs. They don't have the expertise, and this, of course, has a high pressure for those with a psychiatric condition and their families, because sometimes, again, the length of stay can be longer than a day or two. So there's a long wait for consultations. So why is the increase of children to the emergency room? Well, we mentioned some reasons, but this is also international, and it has to do with uncertainty of the socioeconomic status, the impact of drugs in general, the increased use of social media. Now, that's not necessarily negative, because, and especially the next one, the reduction of stigmatization increases the willingness to seek help. But when you don't have those psychiatric services available, what patients end up doing is going to the emergency room. So it's a default state, a condition. So in New Mexico now we have a psychiatric emergency service that also treats children and adolescents. And let me show you, this is the increase of visits in the psych emergency service. As you can see, it is in the minority population. Interestingly, New Mexico is a majority-minority state. The majority of those of us in New Mexico come from a minority group, so more than 50% of the individuals. Hispanics, 91%, so considering, actually the majority of the population of New Mexico is Hispanic. So that has had major consequences in New Mexico. Now, as you can see, this is the number of visits that have increased in the emergency room for the reasons that we have mentioned. And let me show you some, let me go to some graphics. I want to show you some graphics. This is by year. As you can see, during COVID, you can see 2019. Actually, during COVID, the visits decreased, but then it started to increase, and then it went down, but still it's higher than before. Most of the visits had to do with depression. This is psychiatric visits coming for depression. This is by age group. As you can see, it's mostly adolescents. There is in terms of the hours, as you can see, 24 hours is the highest. There's no difference between gender. Now, this is good. This has to do with, was the patient seen by a mental health expert? When it comes to marijuana, not necessarily, but many times they come up for some other reason and patients don't mention that they use marijuana. Now, this is key. When it comes to depression, the majority of patients are seen by a mental health provider, which can, of course, be part of depression, and also psychosis. So those are good data. So we now have this crisis center that we can see adolescents and adults, and the visits have actually doubled. So we, compared to before we had the center, have doubled day by day. So this is the balloon fiesta. It's the best known thing that happens in New Mexico every October. So thank you for your attention.
Thank you so much, Dr. Tohen. Now we will open the floor for questions. Any questions online?
Actually, what I also would welcome, questions, of course, but comments. How does the data that I shared compare to data in Ontario, or for that matter, in Toronto? Do we have an epidemiologist here? Any thoughts, Ben? Sorry, have to go to the boss.
You're asking about the pattern of emerge visits?
Yeah, and exactly.
Yeah, it was the same thing. There was an uptick and then a drastic downtick, and then it relatively quickly built back up. And the perception here was that it wasn't a new wave of anything, but just a stress test of the system that wasn't built to be flexible and to compensate for the amount of need that there was. So I think, although the ethnographic differences you mentioned are, of course, important, similar pattern was overall observed here.
And actually, this is we see our obligation to do research in New Mexico, because being a minority state, we can do studies looking at minority groups. In the rest of the U.S. and in Canada, the minorities are a minority population. So if we do the research in New Mexico, where we have the population data that was that we get from the studies in New Mexico, could be applied to other states. Another interesting study that we did was first episode of mania coming to our early clinic. For the white population, most of them came from outpatient or from schools, which is good, because that means they reach the early clinic sooner rather than later. As opposed to the minority populations, the Hispanics and the Native American, most of them came from the inpatient unit. In other words, after they had had the first episode of psychosis or mania. So therefore, what we did is create education in Spanish that would focus on early detection of symptoms, and again, not only for non-affective psychosis, but also affective psychosis, bipolar, but going to the communities and in their own language. So when we advise other states where there's minority communities on what to do, we let them know what you really need to talk to the communities, and for that matter, to the teachers, because otherwise the first visit is going to be an inpatient visit, which is never good.
A question in the back.
So I wonder if we could just follow up on your question, Mauricio, to the Canadians. Mm-hmm. You've had considerable liberalisation of your drug policies over recent years in Canada. Have you seen changes in the emergency room presentations here as well? Like, we're watching in the rest of the world to see what happens. Do you know? Yes.
I defer to my colleague on his data, but I mean, in Canada, what we find is there's more emerge visits, and also a greater percentage of psychosis is cannabis related.
So substance related presentations.
Particularly cannabis.
But you know, something that happens is that since it's hard to get an outpatient appointment in the US, the walk-in clinic is the ED. And EDs are not built to be walk-in clinics. They're built to take care of emergencies, accidents, or potentially lethal conditions. So now the way to solve that is by creating walk-in centers, where patient can be seen whenever they need to be seen, if it's just to talk about do I have this condition or not, or what treatment do I need. I think we have a question there.
Yeah, I have a non-medical question for you. I noticed that you have an MD, a PhD, and an MBA. How do you do that?
I actually went to school until I was in my 40s. And I think it has to do with, I never thought of myself as I'm this great individual. I thought to do good things, I really need to do something that I can do, which is to study. So it's trying to better myself. And I can't complain. It's been good.
Yeah, you should do another talk on that topic. How do you study so much?
Well, I'll tell you what, there's usually the discussion, who are better in doing research, PhDs or MDs? PhDs, of course, because medical school is a profession, as opposed to when you go to graduate school, you learn how to do studies. So I knew of that deficiency with me, so then I decided to do a doctorate. So that's why I did my doctorate in epidemiology. And then when I was working for industry and I was, I guess, becoming a leader, one of the things that I did not have is sort of training in leadership and finances, so that's why I did my MBA. So I think it's sort of a awareness of my limitations. Now, with that, I'm going to say hasta pronto, because I need to get to the airport. So it's good meeting you all. Thanks for having me, Ben.
Thank you so much, Dr. Tohen. It is now my pleasure to introduce our second presenter, Adam Jordan. Adam Jordan is currently pursuing a Master of Science in Food and Nutrition at Western University, a program that combines a dietitian practicum with advanced research and coursework. He holds undergraduate degrees in kinesiology and nutrition and food with a minor in psychology. Adam has published research in the fields of nutrition, exercise, and mental health. Please join me in welcoming Adam.
You can advance with the mouse or the click.
Okay. All right. Thank you, Kristen. So today I'll be talking about addressing malnutrition, an adapted mealtime assistance framework for inpatient psychiatric settings. I'd like to thank my supervisor, Dr. Latifa Ahmadi, as well as a collaborator on this project, Victoria Hansen, a dietitian at CMHA. So the learning objectives today are to recognize the significance of malnutrition in inpatient psychiatric care, to identify personal and organizational factors that can pose challenges to the mealtime experience, and explore how established mealtime interventions can be tailored to this unique context. I do not have any conflicts of interest to declare. All right, so what is malnutrition? There's some debate within the nutrition world what malnutrition really is. We may think of it as someone who is emaciated, without muscle, without any fat, but malnutrition, defined by the Canadian Malnutrition Task Force, is something like an inadequate intake of energy, protein, and other nutrients. And this is important because psychiatric populations, those with serious mental illness, often have 2 times higher risk of obesity. So you can be obese and malnourished because there's higher rates of deficiencies in certain vitamins as well as protein deficiencies. The highest number found in the literature of potential malnourishment is 42.5% in psychiatric inpatients, so that's quite high. It tends to hover around 30%, but that was the highest number. And malnourishment is correlated with impaired recovery, worse psychiatric outcomes, and impaired daily functioning. So to date, there are no studies that describe a comprehensive strategy for mealtime assistance in inpatient mental health settings. There's really not even any research looking at specific interventions in inpatient mental health settings. There is some research, but that's in eating disorder specific wards, and certainly no comprehensive mealtime approach. So our aim was to develop a standardized role-based framework for mealtime assistance in psychiatric care. To do that, we conducted a narrative review, starting by reviewing successful mealtime practices in inpatient settings, then identifying specific challenges in psychiatric populations that can allow us to modify mealtime assistance for their unique needs. We'll skip over number 1 for now and go to the specific challenges in this population that can relate to nutrition and malnutrition. So I divide them into personal factors as well as organizational challenges. Starting with personal factors, there's medication side effects and condition symptoms. There's tons of side effects of psychiatric medications. Here it's showing the side effects of antipsychotics, which are commonly prescribed in bipolar disorder. So there can be dyschezia, bad taste, xerostomia, dry mouth, which can result in impaired discomfort in consuming like rough foods, textured foods, say like broccoli, and also a preference for carbohydrate-rich foods, and changes in appetite. About 80% of the time, there's an increase in appetite, and 20% of the time, a decrease when it comes to psychiatric medications. But as I mentioned, obese malnutrition is something that exists, so even the increase in appetite is a concern. Some others there, you can see constipation can result in early satiety, so feeling full faster, and obviously nausea and vomiting is related to malnutrition. There's condition-related symptoms, so related to disease or disorder symptoms themselves, low motivation, apathy, so that could potentially be seen in the depressive phase of bipolar disorder. Many researchers today also talked about altered circadian rhythms, self-medicating with food. So here's a little quote here: "When I sleep and I wake up and I don't feel well, look for the automatic solution to feel better, and eat chocolate. And of course, we all enjoy eating chocolate to feel better, but that's not necessarily a long-term solution. And paranoia, resulting in food refusal, is also common, especially in patients with schizophrenia. Next, we'll look at the organizational challenges. So looking at rigid institutional practices and lack of education. This is some older research, but essentially there tends to be a prominent focus on pharmacotherapy. And obviously pharmacotherapy is frontline treatment for mental health disorders, but we want to be aware that there are other useful tools like nutrition, like exercise, that can help improve patient outcomes. There's also a lack of education. So this is also a bit older research and in a forensic psychiatry unit in New Zealand. But essentially, there was a severe lack of education for the nurses there. Nurses were getting nutrition education from older nurses, but there was no correlation between nursing experience and knowledge about nutrition. And nurses were often getting nutrition education from magazines, from TV shows, probably not the best source. So, we then looked at existing mealtime interventions in adjacent fields, so not necessarily in inpatient mental health settings, but for example, in elderly care or dementia settings. So there's protected mealtime, environmental modifications, staff and volunteer assistance, as well as oral nutrition supplements and food fortification. So protected mealtimes are periods of time where all non-essential staff activities are ceased. There's no intake of patients, there's no visitors coming in. It's essentially an all-hands-on-deck approach to mealtime. There are some mixed results from protected mealtimes for increasing protein and energy intake. However, specific subgroups, such as those with cognitive impairments, may stand to benefit more, so that's definitely related to our patient population. Some barriers could be missed meals due to that circadian rhythm disruption or potential crises. So we want to ensure that there's consistent wake times, backup trays if necessary, and hopefully PM or protected meal times could be implemented across the hospital or at least adjacent wards, because it's found to be more effective when that's the case. Next, we'll look at environmental modifications. So this is talking about enhancing the mealtime environment. So when there's positive interactions between staff and patients, there's seen to be an increase in protein intake. Some barriers to adequate intake include poor lighting and cluttered tray tables. And then this is an interesting one. So these were 2 studies done looking at acoustic treatment and music. So they first, this was in a dementia ward, I believe. So they first soundproofed the walls and added pictures of food on the walls. And they found that there was an increase in mealtime, social interaction, as well as calorie intake. And then beyond the soundproofing, they also added instrumental music, and there was a further significant increase in all of those variables. Some key barriers in this population could include sensory sensitivities and music preferences. So maybe this is where the lived experience or the patient engagement side comes in, asking patients what type of music they would like to enjoy. However, probably keeping it to an instrumental version would be ideal. And then potentially grouping patients with similar needs together to address the sensory sensitivities component. Now, I won't go to these other 2 in depth in the interest of time, but staff and volunteer assistance is an interesting one. I'm currently analyzing some data on a volunteer mealtime assistance program in an elderly population at St. Joseph's Healthcare. And we're seeing a significant increase in calorie consumption, protein consumption, as well as certain markers of functionality like hand grip strength, CRP, and others. And it's interesting to note that I saw Dr. Michaela Dimmick's poster here that shows elevated CRP is associated with suicide attempts in youth with bipolar disorder. So, that data I was looking at was not in a psychiatric population, but however did show a decrease in CRP, and potentially there's an avenue here for bipolar disorder. And then finally, oral nutrition supplements and food fortification, so providing what we would call mid-meals, so snacks in between meals, as well as fortifying foods with the necessary nutrients, as well as protein where necessary. So that is most of it. I hope you can see that malnutrition is a problem in inpatient psychiatric care. The highest number was up to 42.5%, and it's often not screened properly or not detected properly because of the higher incidence of obesity in this population. But there's a lot of personal and organizational challenges that can come into play in adapting mealtime care practices to this population. There's both organizational as well as personal factors. And overall, there's not really that much research in this area. As I mentioned, there were specific interventions done in eating disorder populations. However, there's nothing done in just a general mental health setting, let alone a whole framework for that. So that is it. I hope you enjoyed my talk, and I'm happy to take any questions.
Thank you so much, Adam. I see a question right here in the front.
Thanks. Very interesting. So I wonder, in any of your research, have you shown that changing the type of food or the variety of food presented in the psych ward would be beneficial to decreasing malnutrition? Anecdotal evidence, when I was in the hospital, I let them know that I was a vegetarian at the time, and they said, oh, there'll be food for you, don't worry, and there wasn't any. So I tried to check myself out of the hospital, and it all ended fine, but that seems to be a real barrier.
Yeah. That definitely seems like it would be a barrier. One interesting part, I didn't get to this, but for the oral nutrition supplements and food fortification, we kind of addressed the specific needs, so that patients may have the dyschezia or the xerostomia, so maybe they may need different flavors or like consistent time of drinking a lot of those to not have the dry mouth as much. In terms of vegetarian, I think at this point most inpatient hospitals should have vegetarian options, and that's really unfortunate that you didn't, but I would hope they have that now. Yeah. I think we're probably more aware of the different needs, whether it's gluten-free or vegetarian. But thank you.
Hi, sorry. I know this is primarily on inpatient psychiatric supports. I do work at a community organization, and I think the biggest barrier I face with my clients is that they are all food insecure. So it's just an overall, they're lacking everything from their diet. They're not getting to eat 3 meals a day. Like snacks are completely out of the question. So when I'm dealing with clients that are food insecure, living in a remote area, not a lot of access to food, what are the best things I can do to kind of bolster their diet and bolster their dietary intake, when they're living that way?
Yeah, no, it's definitely a problem, and even there's some, when I talked about that 42.5%, oftentimes out of hospital, it's even worse than that. In terms of, I can't really provide recommendations, but what kind of, are you a social
Sorry,
worker?
I'm a nurse with the early psychosis intervention program. So my clients are all first episode psychosis, and again, they're kind of missing overall just not good diet in general. So are there any specific, vitamins, supplements that would ideally be added to their diet?
Yeah, I guess you have to consider getting that intake, but keeping it at an affordable price. So, I guess my wish is that all of these patients would be able to see a dietitian at some point and have all that information provided to them. But unfortunately, can't really answer that too much at the moment, but thank you for your question.
Thank you.
I'll just add a comment, Adam. We've had presentations on obesity in the past and binge eating, but this is the first time ever that we've had information shared with us about nutrition. It's been very eye-opening, and I just want to thank you for opening that door for us, and we hope to keep it open.
Thank you, Dr. Goldstein.
Thank you, Adam. I'd now like to present our third speaker, Dane Mauer-Vakil. Dane is a PhD candidate in the School of Public Health Sciences at the University of Waterloo, specializing in health evaluation. His current research focuses on mental health services, systems, and policies at the intersection of forensic psychiatry, bipolar disorder, and substance use. He is also involved in research on bipolar disorders related to psychosocial care and community health systems. Dane has a strong interest in applied health services research, particularly using implementation science approaches, with the goal of improving the lives of individuals with or at risk of bipolar disorder. Please join me in welcoming Dane.
My notes here. Just the arrows?
cameras work or the mouse.
Okay. All right, good afternoon, everybody. Thank you, Kristen, for the introduction, and to Dr. Goldstein for providing me the opportunity to speak here today. I also want to thank the CUIBD team for their work in putting together this conference. The title of my talk is a comparison of two psychoeducation groups for persons with bipolar disorder, life goals versus Changeways, and importantly, I'd like to acknowledge my collaborators from Queen's University. I have no conflicts of interest to declare. So the learning objectives for my talk are threefold. Firstly, to compare the life goals and Changeways psychoeducation programs pertaining to impact on functioning for individuals with bipolar disorder. Secondly, to examine the interplay between depression, anxiety, and hope in the context of psychoeducation for bipolar disorder and its implications for program retention and treatment outcomes. Thirdly, I'll explore select bipolar disorder psychoeducation programs currently under development. And importantly, this talk aligns with the conference learning objective related to identifying and implementing evidence-based psychosocial interventions for the treatment of youth bipolar disorder. So psychoeducation is considered a cornerstone of management for bipolar disorder, equipping individuals with the knowledge needed to better understand and manage their condition. Group psychoeducation in particular has been shown to be effective for individuals with bipolar disorder, given that medication alone is oftentimes inadequate for symptom management. Current psychoeducational literature highlights its benefits, including reduced relapse rates, improved medication adherence, enhanced psychosocial functioning, as well as cost effectiveness for the health system. Now, importantly, the CANMAT and ISBD 2018 guidelines for the management of patients with bipolar disorder recommends psychoeducation to all patients and their family members for relapse prevention, and they also state this intervention to be of first-line maintenance. So for several years, leading up to 2016, Providence Care Hospital in Kingston, Ontario offered two programs for outpatient treatment of persons with bipolar disorder, Changeways and Life Goals. Now, the Changeways program was initially created for adults with unipolar depression. Its modules encompass goal setting and stress management, depression and lifestyle, cognitive behavioral skills training, social life roles, and relapse prevention. And for this current project, applications to mania and hypomania were added to each module. The Life Goals program followed a systematic educational framework emphasizing individual application of illness management and goal setting. And the key distinction between the two programs that I'd like to make is that, generally speaking, the Life Goals program is rooted in behavioral and self-regulation theory with a recovery-oriented focus, while the Changeways program had a stronger CBT basis. So the study objective was to compare the Changeways and Life Goals psychoeducation programs regarding clinical psychosocial outcomes as a quality improvement initiative to inform future clinical practice at the hospital. The Life Goals group consisted of 6 one-hour sessions on illness management and 20 one-hour weekly sessions on goal setting, while the Changeways group consisted of 13 two-hour CBT sessions, and both groups equated to a total of 26 hours of group therapy. 79 adult participants completed measures at baseline and follow-up pertaining to anxiety, depression, mania, social adjustment, satisfaction with daily occupation, hope, and quality of life. And I've listed here on the slide our data collection instruments. We ran pair sample t-tests to examine the data longitudinally, chi-square tests of association to examine sex differences, and Spearman correlations to assess associations between the measures within the groups. Now, unfortunately, I won't be able to share any numbers on this slide since the hospital laptop that I was using back in 2016 to house this data and run these analyses for the project could not be retrieved, but I will speak to the general findings. So participants who completed both psychoeducation groups observed either maintenance or improvement in overall psychosocial and occupational functioning. Furthermore, a notable relationship existed involving measures of depression, anxiety, and hope in conjunction with program dropout, notably. For non-completers of both programs, strong negative correlations existed between anxiety and depression and hope scores. Now, in terms of the life goals baseline data, completers of the program scored significantly lower in anxiety at baseline versus non-completers and significantly higher in hope. Regarding the Changeways baseline data, completers of the program scored significantly higher in hope versus non-completers. And then finally, both the QLESQ and QLESQ short form measures for quality of life did not yield significant differences between the groups at baseline or longitudinally, and we think perhaps this might suggest that the short form measure is an effective and less time-consuming tool. So the results suggest that higher levels of anxiety and depression alongside low hope scores could be related to a higher likelihood of program dropout. Furthermore, it's possible a measure of hope could be clinically useful as a screening tool for youth with bipolar disorder, and this considers the early intervention focus that I think is very important. Now, given the CANMAT and ISBD 2018 guidelines for managing bipolar disorder that suggest that peer support and group learning enhance the efficacy of psychoeducation, I would argue that innovative programs should be developed, adapted, and scaled. A couple of examples of innovative psychoeducation programs currently under development include work by Emma Morton on the co-design and pilot evaluation of a peer-facilitated group called Thriving with Bipolar Disorder, as well as Cam Karmatian on the feasibility and outcomes of a telehealth-based intervention to enhance health-seeking behaviors in high-risk youth. And this program is called Psychoeducation and Resilience Enhancement Programs for Individuals at High Risk for BD, or PrEP-BD for short. Now, these programs are novel given that unlike traditional clinician-led models, for example, the one that I'm presenting on today, which is somewhat dated, these projects leverage peer facilitation with a quality of life focus. They incorporate telehealth aspects as well as co-design processes with lived experience advisory groups, and we're learning how important that is as well. Now, considering the persistent challenges in accessing traditional psychotherapy in Canada, such as limited availability of trained professionals and geographic barriers, group-based, peer-delivered, and telehealth psychoeducation programs, I think, hold significant potential to increase access as well as equity in mental health care. And finally, future research should focus on the spread and scale of efficacious psychoeducation programs for bipolar disorder, with a focus on improved and sustained long-term outcomes. And I would argue implementation factors should also be investigated. Now, an important disclaimer I need to make is I'm not a clinician. My thinking and research are grounded in the idea that a population health approach is the optimal way to improve health outcomes and thus quality of life for those with bipolar disorder, even if that is somewhat aspirational. My methodological proposition is that each and every newly developed psychoeducation program should be rigorously evaluated, and that many learning health systems should be created where data leads to knowledge that informs clinical practice, which in turn generates more data, and the cycle continues on as such. So from a program evaluation method standpoint, I argue that this should include creating logic models to outline inputs, activities, and outputs, as well as outcomes alongside continuous cycles of process, outcome, and impact evaluations. So in conclusion, this study compared the Changeways and Life Goals psychoeducation programs for bipolar disorder at Providence Care Hospital in Kingston, Ontario, as a quality improvement initiative. I examined the interplay between depression, anxiety, and hope in the context of these programs, explored a couple of bipolar disorder psychoeducation programs that are currently under development, and I proposed a methodological framework for evaluating these types of programs using population health and learning health systems. And here are my references. And yeah, thanks for your attention. I'm happy to take some questions.
Thank you very much, Dane. Do we have any questions from the audience? Yes, I'll ask a question. So you did your pilot data on adults, right?
That's correct.
For this project. Because we are interested in youth bipolar disorder, what do you think would be a main difference in the acceptance of this sort of psychoeducation? Do you expect there to be a difference in adherence to the program, or?
Oh, that's a good question. I would like to think that youth would want to be engaged in this type of therapy. Again, I'm not coming at this from a clinical perspective, but I would think that some folks early on in their illness or recovery journey may be hesitant to engage in group activities. But I'm not sure. I'd be hopeful from a data perspective. I would like to look at that, but I'm not really sure.
So thinking back to the presentation from Dr. Vasilev about self-stigma, I just wonder if you would speculate about the potential link between educating people about bipolar disorder and changes in stigma that wasn't a core focus, but that might be potentially one of the mechanisms of how psychoed works.
Yeah. I mean, I would argue that the type of program that Dr. Vasilev has developed should be integrated into these types of psychoeducation programs. I think I worry that if it's peer delivered, there may be kind of issues with getting that messaging across, given that it's very, I think it sounds like it's very difficult to do, and there's language considerations that need to be made. Again, if that was created and there was a data set that was available, I would love to look at it. But I would lean on Dr. Vasilev to widely implement her program, and then we can look at those data.
I guess what I was suggesting was that potentially psychoeducation is implicitly or unintentionally an anti-stigma intervention by virtue of explaining to people that it's not like a character deficit, or so just wondering in terms of the components of psychoed, if you think any of that aligns with people distancing themselves from the idea of being personality-wise flawed.
Yeah, again, it's difficult for me to speculate without the clinical background. I don't know how those conversations happen one-on-one or in groups. But if Dr. Vasilev wants to chat with us about that informally, that would be great.
So perhaps something I should look at is incorporating psychoeducation programs that have a strong evidence base or an evidence base into the psychoeducation that's in my program, because Dr. Goldstein is right. Psychoeducation in and of itself can be a great reduction in stigma and in self-stigma. Once people, they say knowledge is power. Once you understand, you get it and you feel less bad about it. So perhaps I could learn from you in that sense.
Yeah, let's work together on that.
Thank you very much to all three speakers. Now I'll invite Dr. Goldstein back.
So Kristen, you were so efficient in running this group through their paces that we're a bit before the coffee. And what that means is I'll take the opportunity, rather than at the end of the day, to share with you the news about today's two poster winners, so that you, while you're still here, can congratulate them. So two poster winners. One is a poster by Maggie Dobbin and Juliana Botros, pardon me for my pronunciation, investigating the safety of lithium use for youth with pediatric bipolar disorder. Maybe you guys could stand up so people know who you are and they can come and pat you on the back. There you go. And the second is Andrea Chiorian, prescribed psychostimulants and other pro-cognitive medications in bipolar disorder, a systematic review and meta-analysis of recurrence of manic symptoms. Congratulations. So it'll just be a matter of a few minutes until we have fresh coffee, so feel free to stand up, stretch, talk to some people, and then we'll have our final session of early career investigators next.